All right, we're going to talk about chapter 52, the child with a neurologic alteration. The two diseases that we're going to talk about in this chapter are spina bifida and cerebral palsy. We're going to start with spina bifida, which you can find on page 1283 in your textbook. Spina bifida is a congenital neural tube defect classified by incomplete closure of the vertebrae. It can be considered spina bifida occulta or spina bifida cystica. Clinical manifestations include a small tuft of hair or dimple on the lower lumbar sacral area. Diagnostic evaluation includes alpha fetoprotein levels in blood at 16 to 18 weeks, amniocentesis and fetal ultrasound, a CT or myelography. Therapeutic management includes prenatal microsurgical closure, surgery following birth, and the patient can have lifelong neurologic, orthopedic, and urinary problems. This diagram that you see on page 1285 in your textbook shows some of the different variations between the different types of spina bifida. On the left, spina bifida occulta shows no herniation of spinal cord or meninges, and it does have that hair tuft. Next to it in the middle, spina bifida cystica meningocele, you see a sac-like protrusion containing meninges and cerebrospinal fluid. And then finally, spina bifida cystica myelomeningocele, a sac-like protrusion is filled with cerebrospinal fluid, meninges, nerve roots, and spinal cord. So obviously that one being the most severe of the three types. Under manifestations relate to the degree of deficit, which is determined by the level of the lesion. Children with spina bifida are at a higher risk for developing latex allergies. Approximately 73% of children with spina bifida have a latex allergy. If you see on page 1286 under the pathophysiology of spina bifida, the degree of impairment again corresponds with the level of the defect on the spinal cord and the size of the defect. The lesions, 90% of spinal cord lesions are at or below L2 vertebra. The lesions result in paralysis, partial paralysis, and varying sensory deficits. Club feet, scoliosis, and contracture and dislocation of the hips often accompany the deficit. Meningocele is a sac-like protrusion filled with spinal fluid and meninges. The most severe form is myelomeningocele, in which the sac is filled with spinal fluid, meninges, nerve roots, and spinal cord. Under diagnostic evaluations, we talked about already the alpha fetoprotein levels in the blood at 16 to 18 weeks of gestation. If they're elevated, an amniocentesis and fetal ultrasound are performed. After delivery, the infant may undergo a CT scan or myelography. Under therapeutic management, again, talked about the prenatal microsurgical closure of the myelomeningocele performed at approximately 19 to 25 weeks of gestation. Shows promise for reducing the severity of malformations and incidence of hydrocephalus. Risks associated with prenatal surgery include premature birth with its associated consequences and possible fetal death. Maternal risks are also including abrupto placenta, preterm membrane rupture, preterm labor, wound infection, chorioamnionitis, uterine hemorrhage, loss of uterus, and damage to adjacent organs are directly related to the hysterotomy. Following birth, immediate surgical closure of the defect decreases the risk of infection, morbidity, and mortality. The child will need lifelong management of neurologic, orthopedic, and urinary problems and is best managed in a multi-specialty outpatient setting. Here's a picture in your textbooks of this infant who has had a repaired myelomeningocele, and it says to note the left club foot. The deformity often accompanies the defect because normal intrauterine movement does not occur in the fetus with spina bifida. We're going to move on and talk about cerebral palsy, defined as a chronic, non-progressive disorder of posture and movement. Patient will have difficulty controlling muscles. Comorbidities include cognitive impairment, hearing and speech impairment, visual impairment, and seizures. Manifestations, there's a whole bunch listed here, but the first one says it all. They vary widely. So the manifestations of cerebral palsy can vary widely depending on from patient to patient. Some of the manifestations include persistence of primitive reflexes, delayed gross motor development, abnormal muscle tone, lack of progression through developmental milestones, abnormal posturing, spasticity or uncontrollable movements in the extremities, disturbances of gait, seizures, attention deficit disorder, sensory impairment, equilibrium issues, speech and swallowing impairments, and the child may be intellectually intact. So it's worth noting that even with the other deficits the child may experience, that they may be intellectually intact. For diagnostics, EEG, CT, MRI, electrolytes, looking at different labs, a thorough history, complete neurological exam, assessment of developmental disorders, genetic evaluation for patients with congenital malformations. The goal of managing the child with CP is early recognition and intervention to maximize the child's abilities. Cerebral palsy often is not diagnosed before the child is 2. Again, the child may be intellectually intact, but this factor can be overlooked because of the child's physical limitations. Therapeutic management can include medications for spasticity. Intrathecal baclofen, a skeletal muscle relaxant, can be administered via an infusion pump and can be used to treat severe spasticity in children with CP. Benzodiazepines are also used to treat spasticity. Botulinum toxin A, or Botox, can be injected into the muscle. That is an option for non-ambulatory children to help with comfort and care. When studying about cerebral palsy, if you look on page 1289, if you can on your own review the pathophysiology chart there, and then below it the purple nursing care plan box for the child with CP.